Could you take your seats, ladies and gentlemen? We're about to begin. Well, I seem to have fused all the lights now. Anyway. Okay, thank you for returning so promptly. Welcome to the third session of our annual conference. This, of course, is of pretty primary importance because the impact of UK Biobank on health outcomes is ultimately what is going to represent success or failure to us. We've seen an awful lot of success already today, and I think we'll see some more in the next two sessions. I think the success of UK Biobank is doubly important because due to the care and attention to detail and sheer perseverance of the UK Biobank team, I think we are on the way to slaying a UK shibboleth about the fact that using people's health records for research purposes and to understand better what will improve their health outcomes is somehow the work of Satan. And whilst we may congratulate ourselves on having an awful lot of wonderful rich data in the National Health Service, gaining access to it remains unnecessarily problematic. And I think the success of UK Biobank is ultimately going to be vitally important to explaining to the UK public just why they have nothing to fear from allowing their health data to be used in the right way with the right controls by appropriately managed people to do important medical research. So congratulations to UK Biobank for leading the charge in that very difficult area. The other thing that, to me, characterises UK Biobank has always been planning. Sir Rory reminded us this morning of the period between 2003, the formal establishment of UK Biobank, and the launch in 2006. But of course, a lot of planning went into the establishment phase for the 3 or 4 years before even that. So we are coming up to a 20-year time point for UK Biobank. And when I look back, I think that prolonged period of analysis and reflection before the start meant that UK Biobank avoided a lot of pitfalls that it otherwise might have stumbled into. So planning is vitally important, and we're going to hear in the next session about some of the things that UK Biobank is currently having to wrestle with. I describe them as the challenges of success. So to give you one example, it is not going to be possible for you all to download the whole genome sequences of 500,000 people, because that will require more electrons than there are in the universe. And so already UK Biobank is starting to think about the different way that the research community can access that type of data, and that may be much more about you coming into a biobank resource rather than the biobank resource coming out to you. And I think Mark is going to give us a little flavour of the thinking on that later. So let's kick off, and our first speaker is Robin Flagg, who's going to tell us about some of the follow-up studies in Biobank. And you've seen this morning how important a component of the overall programme those are. So Robin.
My name is Robin Flagg, and I'm the UK Biobank Data Linkage Program Manager. And I'm going to be discussing how do you follow up 500,000 people across England, Scotland, and Wales, and hopefully keep you awake in the after lunch slot. So, let's see if I've got this right. Okay. No. This one.
Is this the key?
Oh, it's that one. Okay, thank you. Thank you very much. So, our aim is to identify a wide range of incident diseases occurring in our biobank participants after recruitment. There are generally considered to be two methods to follow up biobank participants in cohort studies generally, and they are being described from the participant point of view. So the first is active methods. This is traditionally face-to-face interviews, sometimes postal or web questionnaires, and this data can often be processed quite quickly and can be quite costly and time-consuming, and also make it difficult to get complete follow-up because you often are only engaging in with those people who are most capable of being followed up. The other is determined passive, and I have to say I find this term a misnomer, speaking as the person who has to obtain the data linkages. It is not a passive method at all from UK Biobank's perspective. So, why is passive follow-up even possible? Well, first of all, it's possible because all of our participants were registered with an NHS GP at the time of recruitment, which means that we can follow them up through linkage to NHS records. And that means that we don't have to interact with our participants. We can just get on with the work. This should be effective and cost-efficient, and it often is. And I have to say, having done this job since 2012, it is getting better. It is getting easier. And the data suppliers, NHS Digital, ISD in Scotland, the University of Swansea in Wales, are all really, really helpful to me and have made this easier and easier. We also obtain broad consent at recruitment, and that means that we can link, and we do have an advantage over some other projects that try and obtain this linked data. However, there are some caveats about this passive method of follow-up through linkage, and one is that we can only access conditions that are diagnosed in a healthcare setting, and the data has to be good. Those are the two main issues. So we do both kinds of follow-up. We do web questionnaires. At the time of recruitment, we obtained email addresses for about 350,000 of our participants. And since 2011, we've been doing online questionnaires contacting these participants. And over the years, we've gotten better at this, and we get higher and higher response rates. And I would say this slide is slightly misleading because it has a year of these assessments, but in fact, for all of the ones that have happened, we actually leave these surveys, these questionnaires open with the exception of occupational health and the 24 diet recall. So if a participant wants to see what UK Biobank's been doing and they kind of take a wander around the website, they can fill out these questionnaires at any time. Currently, we're doing the dietary preference questionnaires and are actively contacting participants to invite them to fill this out. And we have some follow-up questionnaires that are going to be occurring over the next few years, including a cognitive function repeat and a mental health repeat, but also looking at new things like sleep and autistic traits. And what you'll notice about all of these topics is these are areas that it's very difficult to get information on via health linkages, which is why the active follow-up is also very important. And this whole program of work is run by Naomi Allen and Joe Holliday out of University of Oxford team. So this slide should be a little familiar. Rory showed it this morning. So we receive regularly updated information from NHS data sets in England, Scotland, and Wales. And you can see that for the data that we release is around deaths, cancers, and admissions to hospital. And these provide many incident cases of disease in lots of different areas. As Rory said, it also provides prevalent cases of disease because these data sets go back quite a long way. One of the kinds of data we receive, primary care data is obviously could add hugely to UK Biobank, but I'm not going to discuss it because that is the subject of the next talk. So looking at cancer, which in the UK, because of the cancer registries, the data is really robust and the cases are really well defined. The data is good. We have all this data available, and you can see at recruitment what the prevalent rate of these cancers is and the incidence, and what we predict will be the incidence by 2022. But as good as the cancer data is, there are potential linkages that could make it even better. And these are areas that we're looking to link to, but it's more challenging because essentially these are regional data sets. And so we're working with different teams, particularly in Leeds and Newcastle, to try and link to histopathology reports and digitized histopathology slides and maybe tumor specimens. So what data is available via Showcase? And here I want to kind of caveat because it's very challenging. These data sets, lots of researchers use them, but almost no researchers link them together across the 3 nations. And they are different in each country. And so one of the challenges Biobank had when we received all this data to begin with was, how do we harmonize these data sets? So right now we have death, cancer, and hospital admission data available to researchers, and we do receive annual updates of all of these data sets. And we hope to provide annual updates to Showcase of these data sets as well. But there are many other data sets in the UK that many of you are familiar with, and some that are more unusual. And we are currently in the process of trying to determine which of these data sets makes sense for us to process and release, because it is no small thing to process these data sets. So for example, we've had the outpatient data for quite some time, but because it only holds the kind of appointment that was held and the date of the appointment and very few clinical codes, we haven't had the energy, and we don't know if it's worth processing. There's accident and emergency data that we have almost across the 3 nations, and there are many other registries and audits and emerging data sets across the country. And these data sets, there are many more that I could list, but trying to keep it to one slide, that are emerging and that people are working to create, such as NHS laboratory data. And UK Biobank is working with all the groups who are trying to release these new data sets, create these new data sets. And as they become available, as we assess them and see if they add breadth of data or depth of data, we can then plan to release them. So if you would like to help or make suggestions about data linkage, please contact me. And if you have questions or ideas for web questionnaires, please contact Joe Holliday. Thank you.
Okay, without more ado, let's invite our Chief Operating Officer, Mark Effingham, to tell us about linkage processes. Mark.
The big green button. Okay. Thanks, Alex. So this next session is really a chance to provide a very brief update in 2 areas. The first around the progress we're making in terms of linking to primary care records for the cohort. And the second area around where we are with making available the primary care data that we do have today and incorporating it into the resource for use by researchers. So just to start, getting access to primary care records is critically important for a prospective cohort study such as Biobank. If you look at the outcomes that will be of most interest to researchers using the Biobank resource, many of these will only have kind of codes that are found within primary care data. And if you look at the table, for example, diseases such as dementia, which are predominantly handled within a primary care setting, will be found within primary care data more than secondary care. And you'll see just by the differences in ascertainment rates of what we'd expect by adding primary care to the resource. So this really is a matter of huge focus for Biobank at the moment in terms of how we complete the primary care linkage. So there are a few challenges with getting access to primary care that makes this a little bit more difficult. Fortunately, on a positive note, we do have participants that are each registered with a GP practice in the NHS, and as part of participating in the resource, they gave their consent for us to be able to link to their records. But in the primary care setting, which is quite different to the likes of secondary care, there is no single kind of national source that we can go to get access to those data. So whereas we can engage with the likes of NHS Digital in England and ISD in Scotland for the likes of hospital records, there isn't that flow of primary care to those national bodies. So this has led us over the last 2 or 3 years, particularly in England, to take a different approach, and which has been to work with the main GP primary care system software suppliers in the UK as a way of getting access to these data. And we've had terrific support from TPP, from Vision, what was In Practice Systems via Apollo, and with EMIS in helping us to do this. So in terms of what primary care linkage we have achieved so far, so it's probably worth reflecting back in terms of the progress we have made over the years, and where we started in 2012 with getting access to primary care data in Wales via the Sale Gateway in Swansea. And we have pretty good coverage. It's almost complete coverage, about 95% for Welsh Biobank participants. In Scotland, we've taken a slightly different approach. Here we've been working with a company called Albasoft, who have software installed in a large number of GP practices across Scotland, which gives us access to primary care records through that mechanism. Again, we have pretty good coverage rates, about 75% and rising. It's a different story in England, and this is where we have really been focusing over the last couple of years working with the primary care providers. And in 2016, we worked very closely with TPP, and we were able to get access to a little over 160,000 participant records. And then a year later, working with Vision via Apollo to get access to around another 19,000 or so. So at the moment, we have around almost half of the resource where we have primary care record linkage in place. So you may be asking, why is it taking so long? And actually, that model of working with the GP system suppliers worked really well. We were proceeding on what we refer to as kind of an opt-out basis, where we would write to all of the GP practices, explain what Biobank is about and the scope of the resource, explain what we were looking to get access to in terms of coded data and the basis of our kind of legal consent to be able to do that. And that model worked really well. And in terms of engaging with those TPP practices, out of a little over 2,500 practices, there was only one that chose not to participate. That opt-out process was endorsed by the Information Commissioner's Office in the UK, and also endorsed by the Royal College of General Practitioners, the RCGP. But there were concerns raised from other quarters around the process that we'd adopted, and particularly from the RCGP and BMA Joint IT Committee, that led to a pause in these extracts taking place whilst we worked through what those concerns were and how we might address them. So we have been engaging quite extensively with pretty much every stakeholder group you can imagine within the UK setting. So the ICO, NHS England, NHS Digital, RCGP, and again the RCGP BMA Joint IT Committee. And we've had tremendous support from each of those groups, from the likes of Sarah Wilkinson from NHS Digital, who are doing a fabulous job to help us try and get through this approach. We've now got a revised method, which is based on practices opting in, and that's been agreed and has now been endorsed by all of those groups. I think we are optimistic that we'll have success, but it will require getting the attention of GPs in what is already quite a pressured primary care environment to be able to get their attention to opt into this extract to allow these data to flow for Biobank participants. In terms of how we are trying to maximize that success of that engagement, we do have statements of support from many different individuals. So one here, for example, from Professor Helen Stokes-Lampard, who's the chair of the RCGP, who again has been terrifically supportive of this process. And we have similar statements of support from other groups, such as Sarah Wilkinson, NHS Digital, and Professor Dame Sally Davis, CMO for England. And we're hoping that this will help build confidence with the GPs and get their attention. So, as I mentioned, this revised approach does have endorsement from all of those key parties, and particularly the RCGP BMA Joint IT Committee. And we have thought about how we reduce any administrative burden that's placed on GP practices to make it really easy for them to participate. And all they need to do is simply set a flag within the primary care system for those data to flow. So where are we now? We're about to start a pilot. We're going to be writing once more to each of the practices across England. Also, we'll be doing the same in Scotland and elsewhere, but the focus at the moment is about England, to seek their opt-in to this data extract for consented participants. The pilot mailing will start in the next 2 or 3 weeks, and that will go out to an initial mailing of around 600 practices to get feedback and any changes we may wish to accommodate ahead of a main mailing which will start to the remaining around 6,000 practices across England later this year in September timescales. We do hope with the level of support and things we put into this, we're providing a lot of additional information in terms of frequently asked questions, thoughts in terms of how practices can reduce any of the kind of burden from an information governance perspective, and we're hoping that we'll have a strong chance of success, and that in Q4 this year, provided we have a substantial enough number of practices that have opted in, that we will then do a further extract across England, and then we will look to repeat that on an annual basis going forward. And hopefully we can come back this time next year to report on that success. So that's where we are in terms of getting access to those data. For the data that we have in Biobank today, so as mentioned, we have about half the cohort covered, so around 234,000 participants, and some teaser tasters that kind of links to somewhere in the region of 120 million clinical events and over 50 million prescription items. This data set will be made available as an interim release in the very near future. It only contains coded data, so there's no unstructured data being provided, but it's coded data that we think will be of most importance for epidemiology purposes for the resource. And it's focused on clinical events, prescriptions, lab results, immunisation records, and similar. Now, for those who aren't close to the way that primary care works in the UK, there are a number of different coding standards in use today, so different variants of READ, which is a coding standard used in the UK, so version 2 and version 3. There is a general move within the NHS to move to a common coding classification based on SNOMED CT, and we'll see that, I think, emerge with more maturity in the coming months and years. But for now, we'll be making available those data in their native coding standards within the resource, with only a limited amount of data curation applied. So as I mentioned, this will be an interim release. As Robin said earlier, we'll be looking to provide refreshers of these linked data on an annual basis from 2020 and going forward. The way that we'll be providing access to the primary care records will be through the existing online portal which researchers can use for access to the hospital episode statistics data. But our intent, just recognising that this is quite a complex administrative data set and again requires some understanding of different coding classifications. Our intent is to provide a number of algorithmically derived kind of outcome fields that we can incorporate in the resource. And again, I won't steal Kathy's thunder, and she'll talk about that in a little bit more detail in a moment. And in terms of timelines, the anticipation is that we'll be making the record level data available in early Q3 this year. So this is our main focus right now, building on the showcase release we had back in March for the exome and biomarker data. This next version will be focused on the primary care data. If we can, we'll be looking to include these derived outcome fields either coincident with that release or very shortly thereafter. So please keep an eye out for emails from the Access team in terms of the future showcase releases, and more information will be forthcoming. And with that, just want to say thank you particularly to those supporting groups who've been working very closely with us across NHS England, NHS Digital, and particularly the RCGP, and the very helpful support we've had from the RCGP, BMA, Joint IT Committee, so thank you.
Thank you, Mark. Someday you'll get a medal for patience. Fantastic. I thought for a moment Kathy had run off and left us, but she's back. Just by way of a slight warning, I'm not sure that the video we were going to show from Russ Altman from Stanford is going to be available. What's arrived from California seems to be corrupted, but we're working on that. So at 2:30, I'm hopeful still, but I'm sorry, but we may have to disappoint you. But next, let's hear from our Chief Scientist, Kathy Sudlow, about the all-important issue of phenotyping the participants. Kathy.
Thank you very much, Alex. So, all of this linked healthcare data, and how do we convert it into useful information, particularly for research users who want to study large numbers of phenotypes but perhaps aren't so familiar with the healthcare systems that are used in the UK and with the challenges that those present. So you've seen slides similar to this before, showing the 4 main sources of data that we have, and the fact that we have coverage for death, cancer and hospital admissions data for our entire cohort, and currently just under half the cohort for primary care information. The types of data that we have, you can see here summarized on this slide, and they're relatively straightforward for the top 3, so dates and information on cause of death, site, stage and grade of cancer, or in the case of hospital admissions, diagnoses and procedures. In the case of primary care information, the coding systems cover a lot more types of episodes. So not only are diagnoses coded up as are procedures, but symptoms and signs are also coded. So, for example, things like wheeze or low mood, rather than necessarily a diagnosis of asthma or a diagnosis of depression. Specialist referrals are coded up as well, as are prescriptions and laboratory tests in many cases. So that creates great opportunities and great richness, but also additional challenges. And many of you will be familiar with the coding systems that are used for the top 3 of these, principally the International Classification of Diseases, and most of the information that we have from these sources is in ICD version 10, which has been being used in the UK for quite a number of years, with procedures in the hospital admissions dataset coded to something called the OPCS4. In the case of primary care, the coding systems are much more challenging. So in the International Classification of Diseases, if you go down to the most detailed level, there's about 10,000 separate codes. If you rack up back one level, there's about 1,000 different coded entities at a slightly lesser level of detail. That's reasonably straightforward to handle, as is an understanding of the hierarchical nature of the chapter-based coding system. In primary care, in READ version 2, there are about 70,000 different codes for different entities across those different types that I've described. In READ version 3, which is now being used widely and is the largest is used in the largest amount of primary care data that we currently hold, there are 250,000 different codes potentially available to GPs to apply. Some of them look as if they mean almost the same thing, but they exist, and it's important to understand that. So that adds a layer of complexity to how we need to help researchers understand these data. And then BNF and DM and D codes are different systems that are used to encode drug prescriptions. So how do we make these data valuable? So in the case of cancers, the mature cancer registration system in the UK is very valuable, and it already provides high quality disease status information. So with the exception of looking at the added value of those regional resources that Robin was talking about, there isn't a great deal we need to do to make that easier for researchers to navigate, and it uses ICD, which is generally well understood. For non-cancer conditions, as Mark was alluding to, we plan to rapidly create disease status flags for around 1,000 conditions based on the 3-digit level of the ICD-10 coding system. So that covers a very wide spectrum of disease conditions, and using resources available through NHS Digital here in the UK, we've been able to use the mappings that are available within their system between ICD-10 as a well-understood spine and READ2 and READ3, those rather more complex systems that are available in primary care. And we've also mapped information from participant self-report at baseline across to ICD-10 format. And that's what's enabling us to do that. So that means we can combine information from self-report at baseline, the hospital admissions, primary care, and the death registry information, and map it all to an ICD-10 format. So that's not going to be perfect, but it will give coverage for a wide range of diseases. So what are the limitations of these linked healthcare data for assessing participant outcomes? Well, first of all, they're pretty messy real-world data. They're collected at the clinical coalface. They're encoded by coders who usually sit in the windowless basements of hospitals and aren't paid very much money, and that's where they come from. It's actually amazing that they are as good quality as they are, and although they're not 100% accurate, the rate of administrative errors is really very low. They, of course, are subject to clinical errors as well, and as you know, those of you who are clinicians particularly, patients may be initially diagnosed and labelled with one condition, and then over the course of time that changes, but the code generally will stay in their records. So there's also conflicts within the record of any particular participant. So we will be using and deploying these comprehensive NHS digital map-based tools to combine data across the different coding systems. As I've suggested, they're not perfect and they haven't been extensively validated condition by condition, but they will provide a very useful scaffold for researchers who want to simultaneously study many conditions or want to focus on one condition but take account of others. They will miss cases, and that's because the mappings through to the primary care data focus on diagnosis codes. And as I mentioned before, there are many codes that are used in primary care settings that may signify a diagnosis without a diagnosis label being applied. So, for example, the combination of wheeze and prescription of an inhaler might signify asthma or COPD, or repeated referrals to a COPD specialist nurse assessment clinic might signify a diagnosis of COPD without that diagnostic label actually appearing in the record. And for some diseases, quantitatively, that can be very important. Some conditions are not well captured at all by these health record systems, as Robin alluded to, and those include, for example, many mental health conditions or decline in cognition prior to an established diagnosis of dementia. And they do lack information on subphenotypes for many conditions. So it's common for either for diagnostic labels that specify subtypes to not be used and for a less specific label to be applied, or for them not really to exist in a helpful way that is well understood by the biomedical research community or indeed by clinicians themselves. So to deal with some of those challenges, UK Biobank's been working with experts to create a set of more accurate disease status indicators that are algorithmic combinations of more refined sets of codes for a range of different conditions to estimate the accuracy of these, to consider which additional linkages will add most value, and that's an ongoing exercise which Robin alluded to, and to think about what are the most appropriate scalable approaches for disease subclassification. So here are the areas that we've currently been working on for some time to create these disease status indicators from linked data to add value to the scaffold of 1,000 or so phenotypes that I referred to. So you can see that we've been choosing the areas based on what we think is likely to be of most interest for researchers and the commonest disorders that are likely to be of most interest from a public health perspective as well. So cardiometabolic disorders, stroke, diabetes, MI, cardiac disorders, renal disorders. You can see on the top right there, ocular disorders, and then respiratory conditions, COPD, asthma, inflammatory, venous thromboembolism, and we have a very active mental health group helping us to deal with that side of things. Musculoskeletal conditions, including fractures, which Nick Harvey, who was at the back, has been helping us with, and arthritis, and then dementias and other neurodegenerative conditions. So just to give you an example, for example, if we take chronic obstructive pulmonary disease, where do the cases come from? So in those participants from whom we have information from self-report at baseline, but also through the linkages from hospital, primary care, and death data, the algorithm that we've constructed contains about 15 ICD codes, more than 40 read version 2 codes, and more than 150 read version 3 codes to take the landscape of all the coded data into account. And you can see that if we look at cases that were detected prior to recruitment, you can see that quite a large proportion of them are detected only through baseline self-report. If you look at incident cases that are detected after recruitment, you can see how important primary care data is as a source of this condition, with nearly 60% of the cases being detected through linkages to primary care data alone, because they're not associated with a hospital admission or haven't been yet. In terms of accuracy, we've been reviewing the published literature to see how accurate these coded data are for identifying cases of disease. And here's a summary of some of the work on dementia, summarizing what's out there in the literature, which in summary shows wide variation in different studies, but suggests that the positive predictive value, that is the number of cases identified by codes that are true positive cases, is generally pretty high. It's pretty good for Alzheimer's disease. It's not quite so good for vascular dementia. And interestingly, we have replicated those results largely in our direct studies. So we've been looking at accuracy versus expert adjudication of full free text medical records in a subset of participants in the Lothian region of Scotland, looking at relatively small numbers of cases of disease. And summarized on this slide, you can see that the positive predictive values that are achieved through a process like this are pretty good, and in particular show the power and accuracy of primary care data, which performs every bit as well as hospital data in this regard. So in terms of future plans, what are we looking at doing? So we're thinking very hard about additional data linkages to enhance the accuracy of what we obtain, to ascertain health outcomes that we don't capture at the moment. So for example, we are pursuing linkages with microbiology data sets across the UK, which will add value and health outcomes we don't currently have, and which will enable subphenotyping. So for example, some disease registries and audits may give us more detailed subphenotype and subclassification information not currently available. We've been looking at additional web questionnaires, which you've heard about. We are conducting a number of further regional validation studies to assess in detail the accuracy of the linked data for additional conditions and potentially in additional regions of the UK to look at how generalizable our results from the Lothian region of Scotland are. And we're thinking about the value of making deep dives into the systems of large hospitals, which cover a relatively few number of hospitals, cover a reasonable number of participants in Biobank for disease subphenotyping. So, for example, obtaining information from pathology reports, digitized images and tumor tissue for cancer subphenotyping, from free text or radiology images for subphenotyping of a range of other conditions as well. And finally, which you'll hear about hopefully in a few minutes, we've been thinking about launching a scalable phenotyping data challenge for two reasons. One is to try and look at data-driven ways of automating this process of phenotyping health outcomes, and the other is to engage with an even wider community globally of computer scientists and data-driven innovators who can really help us and the research community to address some of these challenges. Thank you very much.
Thank you, Kathy. Next, then, we have Professor Denny from the United States, who's very welcome today, who's going to tell us something about the importance of accurate phenotyping for association studies with disease. So, Josh, welcome.
Thank you very much. It's a pleasure to be here, as always, and talking about just the amazing stuff that's happening here in the UK Biobank. Let's see. All right, great. So to start with, we've talked a lot about genome-wide association studies and sequencing, and we've talked some about phenome-wide association studies as well. That's going to be the focus of my talk. And just to orient us, essentially what we're doing is thinking about an independent variable and exploring what phenotypes and the range of phenotypes that are available and associated with that, really anchoring on the fact that we have richly, systematically phenotyped sets of individuals, such as the UK Biobank and other electronic health record data sets, which is where this started. Usually that's based on things like billing codes, but I don't want to limit us there. You can think about laboratory values, you could think about natural language processing, and things like that as well. Most of it's been based on billing codes. So to start with, I want to orient us to a discovery study out of the Electronic Medical Records and Genomics Network, eMERGE, in the US. And it was 5 sites that worked together for a carefully validated phenotype that we used codes, labs, medications, natural language processing to find these cases and manually validate who was a case for presumptive autoimmune hypothyroidism. And a control, and we identified a thyroid transcription factor that was associated and replicated this. And then we took a variant, the same variant that was found here, and did a PheWAS on that variant in a slightly larger population, that was unselected, or a much larger population, unselected for any given phenotype. And hypothyroidism was the highest associated phenotype there, but we also had some other thyroid diseases that came up, and things like atrial flutter as associated, which we know that there's, when you're hypothyroid, you're less likely to manifest with atrial flutter. And so this gives us opportunity to look at the performance of these two methods. And so, on the left we have the schematic of the algorithm we used, and then we use these mappings called PheWAS codes or Phe codes, and we usually say there have to be 2 or more that map into that Phe code. And you can see the odds ratios are essentially the same between the 2 approaches. Within our population of individuals within eMERGE, we identified more cases with the PheWAS codes than we did with the algorithm. And so, there's many approaches to PheWAS, and just talking about that, I said most use billing codes. In the US, that's been historically ICD-9 with the clinical modifications, and now ICD-10 after 2015. There's about 65,000 ICD-10 CM codes. And on the right, you can see some of the ways this works. So the Phe codes have numbers that kind of look like ICD-9 codes, but they're actually not. And then what we do is we group, like codes now across ICD-9 and ICD-10 and ICD-10 CM codes to, a given Phe code. And so all the type 1 codes come together, which is not obvious from the ICD-9 coding group system. And then each of those also define ranges of control groups. In addition to the Phe code groupings, there are other groupings. In the US, there's some, the AHRQ has released some software that groups things into about 300 diseases. TreeWAS is another thing. You can also use raw ICD codes, for instance. That gives you a challenge across, of course, mapping between ICD-9 and ICD-10. And you can do many other things. Survey data has been run across the UK Biobank, and other things that I've talked about, like the procedures. So here's another example, PheWAS, driven by EHR data, looking at imputed HLA types into the 2- and 4-digit types of HLA. And you can see, quickly it highlights the fact that there are different associations between class 1 and class 2 HLA alleles, and helps you think about the range of associations. And overall, I think there was 100 or so significant associations, most of which were known, and a few new ones. But what's more interesting is by doing it in a single population, you can actually look across those phenotypes and then look for pleiotropy and see, if you adjust and condition on one and the other, do you see, that that they are truly independent associations. And you can also see, again, a given HLA type, that two HLA types that may put you similarly at risk for rheumatoid arthritis may have differential effect for your risk on type 1 diabetes, for instance. And so that is a tool that you can rapidly explore using this kind of technique. An important aspect is validating its efficacy, and so one of the early things we did using our ICD-9 codes across eMERGE was replicating known associations in the GWAS catalog. We found 86 phenotypes that could be represented in the electronic health record, and a number of SNPs, about 750 overall SNP phenotype pairs. Overall, we replicated 210 of them across a number of disease classifications, and 66% of those for which we were adequately powered in this population of 13,000 people, as well as identifying some novel associations, the top of which we replicated. It also allows us to actually compare the effect size. So here you see something that you would expect to see in that, that the effect sizes from the PheWAS studies are typically a little bit lower than what's in the GWAS catalog. Now, some of that's probably due to the winner's curse, but some of it's also due to the phenotype being not quite as accurate, and it helps you think about the ones that where you have the most error. So the most common error it was really universally type 1 diabetes is often miscoded. In fact, 96% of the time we found type 1 diabetics had type 2 diagnosis codes, and so it made it and the reverse is true 56% of the time. So it caused a lot of inaccuracy in the type 1 diabetes phenotype, and we had trouble replicating some of those SNPs, and we've actually instituted methods to fix that problem, and we can recover those associations. So here's a way you can use PheWAS in concert with a GWAS. So we did a GWAS and eMERGE looking at longitudinal risk of cardiovascular disease on a statin, and found variants that are tied to expression of lipoprotein A were associated with that outcome as a longitudinal analysis, and that risk is increased for those that have kind of ideal cholesterol levels at less than 70. So we looked at a PheWAS of this locus, and as you would expect, you see coronary atherosclerosis near the top, and fortunately we see most of the phenotypes are ones we would expect to see, which gets at the question of if you were to target this with a medication, what potential effects would you see? And so one of the things that's interesting and wouldn't have been on a radar screen is this point over here, which is not quite statistically significant, was lung cancer. So this is a relatively small population of 13,000 people. As it's explored more, maybe that will turn out to be true or not. But it is a rapid tool for highlighting this, especially when you think about the scale of UK Biobank. I mentioned mapping these to ICD-10 and ICD-10-CM codes. Just shows a little bit of the process and the vocabularies and systems that we used in the process with some manual validation. It is in what we call still in beta form. But you can see it covers about 90% of the billed ICD codes in the UK Biobank, and amongst the 10% that aren't there, most of those are not actual disease codes. Only a small fraction of those represent true disease codes. And we did an evaluation at using our data with ICD-9 and ICD-10 codes in terms of PheWAS, and you can see that the effect sizes between in this population was essentially the same for these two known associations with that SNP. So I want to give a few examples. Actually, Kristen showed this earlier, doing a PheWAS in the UK Biobank, and just tons of association associated with atrial fibrillation, genetic risk score for AFib. When they conditioned for the phenotypes, the cardiovascular phenotypes, essentially, those associations went away. But it shows the power of a huge population to show lots of things you expect to see. Here's another one for systolic blood pressure on a large GWAS that was done across the Million Veteran Program as well as the UK Biobank, and just a number of associations showing up with systolic blood pressure. They also did it with diastolic blood pressure and pulse pressure to show that some of these phenotypes overlap, and you see phenotypes that are not exactly associated with cardiovascular disease in here coming out as well, endocrine being one of the more common ones. Here's a resource. Kristen also talked about the SAGE approach to use saddle point approximation to create an efficient and accurate way of calculating these kind of results at scale for the UK Biobank. They have produced a website where you can explore those phenotypes calculated using the same approaches for phi codes across the UK Biobank. And this just shows a particular AFib SNP in that website, and the URL there is there at the bottom. So, we've talked about this in looking at individual phenotypes. And I want to spend the last few minutes talking about phenotypes in clusters and how we think of them. So if you think about, Mendelian disease is a classic example that are often syndromic, presenting with many different features. And those features, are what we may bill in the electronic medical record as physicians, but it doesn't necessarily represent, the disease is not always recognized, or may be recognized later into the disease course, as we heard about earlier with hemochromatosis. And so through the online Mendelian Inheritance in Man resource and the linked human phenotype ontology, we can go from a Mendelian disease to a list of features of that disease which have a vocabulary behind them. And then so our lab mapped those HPO features to phi codes, so basically allowing you to translate OMEM features into EHR phenotypes, and then similar to a polygenic risk score, creating a phenotype risk score that looks similar in process. So aggregating phenotypes up by their weights to produce a score for individual. And essentially you can crank this out across anything for which you have a map and do it at scale. So let's look at cystic fibrosis, a number of features from OMEM, and each of those is mapped to a human phenotype ontology code. And so using our phi code ontology of around 1,800 phenotypes, you can map the ones that line up fairly well to the CF. They're not all exact matches. Some are better matches than others, and then some that we don't have in the EHR, which we're familiar with. And so let's play that out on a couple individuals, hypothetical different conditions. I mentioned they're weighted, so features like bronchiectasis have a higher weight than features like asthma. And so when you go across this, individuals get a different score, and what you find is you can separate cases and controls for cystic fibrosis. Just using the features of disease. So we're not using the disease label, but in this example, we use manually validated cases versus controls who don't have any evidence of the disease in the text record. And we see a very significant result. And we've actually done this for 15 other diseases now. And in every case, except for one, we've seen very strong separation between cases and controls. The one exception is phenylketonuria, which, as you know, in the US is on essentially every newborn screening test. And if you avoid phenylalanine exposure, you don't actually see the manifestations of the disease. So it sort of gives you a test of the effectiveness of newborn screening in removing the features of disease in the population because they generally do not have elevated scores. So we turned this on a population of 21,000 people that had exome array genotyping and looked at 6,000 variants that were rare at a 1% level or less. And we found 18 significant associations, most of which were novel. And importantly, we were able to change the ACMG clinical interpretations for 8 of these variants towards likely pathogenic or pathogenic. So this, using our population, is a paradigm that I think can be explored with larger, rich phenotype populations, such as what is in the UK Biobank. So I want to end with recognition of some of the many people contributing to this work, and the middle row is probably the most important row as the folks actually doing the work. Thank you very much.
Thank you very much, Josh. I hate to be the bearer of bad tidings, but I'm afraid the video from Professor Altman has proved impossible to resurrect. So that gives us an opportunity to invite Kathy to come back to the stage to give us a few insights from her perspective on the scalability of phenotyping.
Thank you. So I'm really sorry I'm not Russ. Just imagine I'm a high-energy male Californian kind of geek with an earring or two, and maybe that'll kind of help you. But we decided that one of the ways in which we might like to address the challenge of making sense of the linked healthcare data and the potential for all the other data in UK Biobank to drive the process of phenotyping the health outcomes of our participants would be actually to use this challenge as a great opportunity to set the challenge to the community. And this really is going to be a challenge for geeks. And to help us kind of set this up and set up something that would be globally attractive to the computer science, health and bioinformatics communities around the globe, we put together a committee of super geeks. So there's a few of us from within the Biobank team, but importantly we have Russ Altman from Stanford chairing this group and others contributing. So Josh, who's just spoken to us, and his colleague Lisa Bastarash from Vanderbilt, Chanchi Kai, who's a statistician and health informatician from Harvard, Sparis Danaxis at UCL in London, Michaela van der Schaar in Cambridge, and Nick Tatanetti from Columbia. And they have been together in a high-energy, high-excitement format, despite the fact we haven't yet had them in the same room. We've been doing this all using video conferencing, have been plotting and planning the launch of this challenge, which will occur later this year. So it will be all about data-driven, scalable methods to create phenotypes, perhaps starting out with some of the conventional disease classifications that we're more familiar with, but ultimately moving towards the definition of new diseases and the recognition of disease clusters that have not previously been thought about or recognized before to really enhance the discovery potential of UK Biobank. So we will be formally launching this challenge later this year. We are going to set up on our website a place where you can register your interest so that we can keep you informed of progress as we plot and plan and pull this together. The exact task will be specified soon. We need to generate a platform to host this challenge to enable people to take part from all over the world. And we need to set in place our evaluation criteria, which may include, for example, genetic validation tools, and you've heard a bit about how those might be used from Josh, or expert adjudicated subsets that can be used as further evaluation criteria. So watch this space, and we really look forward to taking part with all of you and many others in this global challenge. Thanks very much.
Thank you, Kathy, for the second time. I'd like to invite all the presenters then to come and take their places on the platform for a few questions. And while they're taking their seats, could we have the first questioner? And I'd just remind you that the UK Biobank is endlessly interested in your views as to what sorts of things should be done to enhance the resource, so please don't be shy. Question over here.
Hello, I appreciated your heroic attempts to get data out of the GPs, but I wondered if you thought what consequence such an approach will have to every other research study who will not be able to get data out of GPs as a result of your having gone in with an opt-in process. So I represent, sort of, the other birth cohorts in the country, the NHR Bioresource, which have a similar number between them as the UK Biobank. NHS Digital would be much nicer, let's put it that way.
So there is progress being made in terms of putting in place a national extract for primary care. I think there have been several attempts at this previously. None of them have necessarily come into being. I think the work that we've been seeing, and again, Alex Markham has been doing heroic efforts as part of the Oscar sub-team to try and bring the right thinking in place. So I think more than ever, there is a likelihood that some national extract will be in place at some point in the future. I think Biobank would be very supportive of that and would look to intersect with it at the appropriate point. But certainly for now and for the short term, we need to go down this approach.
Thank you. Other questions? Gentleman over there.
I had a question about medication data in the biobank. So currently, the self-reported medications are extremely hard to deal with because there's no standardization with them. I know you're planning on adding prescription information. Is that going to be standardized to RX norm or some other sort of standard when you actually get it into the showcase?
Yeah, so as Mark described, the data that we receive, which comes from a variety of different sources, is the prescriptions are, some of them are read-coded, some of them are BNF-coded, and some of them are coded to DM and D. In the future, when we have coverage of the whole cohort, or nearly the whole cohort, and it's clearer which coding system for prescription should be the dominant one, we will map them all to a common coding system. In all likelihood, we'll do exactly the same with the self-report medications from the baseline, try and map them over in rather the same way we have done with diagnoses using available tools to facilitate that mapping. We're not going to do that right at this moment, not because we don't want to, but because for two reasons. One, we don't know yet what the dominant coding system will be and what the best map would be. It would probably be DM and D, but we would reserve judgment on that for now. And the second reason is we know that out there are large numbers of research groups who are really keen to start working with the primary care data, and we don't want to hold it up. We just want to get it out there as soon as we can. So we will in due course, yeah.
There's a question down here.
Hi, I actually have a question for Josh. Could you explain to me a little bit more about the phenotype risk score? So from what I understand, you're calculating a score for a disease based on other phenotypes, but how do you know if the disease is occurring first and then leading to the other phenotypes? So could you talk a little bit more about the reverse causality issue?
So interesting in this case, we're actually looking at Mendelian diseases. So in some cases, the disease is actually occurring first from the setting of the genetic variant being there and causing the other phenotype. So in this case, let's take cystic fibrosis example and work through that a little bit more, like bronchiectasis, asthma, pancreatitis, meconium ileus. All those features would each get a weight, and that weight is aggregated to produce a score. In general, we aren't necessarily interested in whether it occurs before or after, given it's a Mendelian disease, although we have actually in some cases looked to see whether we find the disease by a risk score before it's clinically diagnosed. For instance, there was a New England Journal CPC case recently where they talked about an older woman who was diagnosed with cystic fibrosis, and we calculated the phenotype risk score for that individual and found that she would be at the 98th percentile. We have found that certain other mutations we can find before it's clinically diagnosed, like JAK2 for polycythemia vera, for instance. But in general, it's more to find it and then potentially give a readout for the pathogenicity of variants as a condition, or you could think about like hemochromatosis and things like that as a good example. Although we find at our institution, people actually diagnose hemochromatosis pretty well.
Thank you. We are about out of time, so could I ask you to, again, show your appreciation for the speakers in this session? Thank you. And we move on now to Professor Allen, who's going to tell us something about our next generation of superstars.
Thanks, Alex. So I think I have the nicest job of the entire day, which is to introduce early career researchers who are really producing some phenomenal research using this resource. So this is the second year we've done this competition, and it's really just one way of UK Biobank kind of recognizing that it really is the students and the postdocs who are the super users of UK Biobank. They're the ones who get their hands dirty. And so this is one way of recognising all the fantastic research that's been done worldwide. So the competition was for early researchers to submit their research abstracts. Second year we've done it. It was a really difficult task, actually, just because of the sheer volume and the high quality of the research that came through. So we had a very difficult job of whittling it down to 20 abstracts. Those are presented in poster form, which I hope you managed to have a look at over the lunch. And we have 2 runners-up and a winner, all of which will present their research to you now. So the winner of this competition unfortunately can't be here today. So hopefully we can have a video of his abstract. So without further ado, I'd like to introduce remotely Dr. Patrick Turley from Massachusetts General Hospital and the Broad Institute. And the title of his talk is Education Can Reduce Health Differences Related to Genetic Risk of Obesity. So can we take it away?
Hello, my name is Patrick Turley. I'm a postdoc at Massachusetts General Hospital and the Broad Institute. I apologize that I can't be there in person today. I'm teaching a course in California, but I'm so flattered to have the opportunity to be able to present this work to you all. My paper is titled, Education Can Reduce Health Differences Related to Genetic Risk of Obesity, and it's joint work with Silvio Barcelos and Leandro Carvalho. It's well understood that education and genetics can each play an independent role in a person's health, but in this paper we ask the question, does genetic makeup moderate the effect of education on health? Or equivalently, does education affect the association between genetic makeup and health? We do this by combining a natural experiment, the 1972 Raising of School Leaving Age, or ROSLA, with polygenic scores in the UK Biobank. The results that I'll show you today are based on an analysis plan that was pre-registered before the full release of the UK Biobank genetic data. So let me start by describing the natural experiment. In 1972, England, Scotland, and Wales increased the minimum age at which a child could drop out of school from 15 to 16. As a result, there was a discontinuous increase in the educational attainment from one birth cohort to the next. We estimate in the UK Biobank sample that 14% of students received an extra year of schooling as a result of this reform. Students born just before and just after the birth date cutoff for this reform should be similar, except that one group was required to stay in school for longer. As a result, any differences in health between the two groups must be a result of the additional schooling. We can use a regression discontinuity design to estimate the causal effect of this additional year of school at age 15 on a person's health. Due to limited time, I'll only be able to discuss the effect of education on an index of body size, made up of several obesity-related measures like BMI, waist-hip ratio, and body fat percentage. We transform this index into a binary variable that roughly corresponds to the BMI threshold for obesity. As our measure of genetic risk, we use a BMI polygenic score, which uses hundreds of thousands of genetic markers to predict risk of obesity. Complete results for our lung health and blood pressure outcomes and for our educational attainment polygenic score can be found in our paper if you're interested. In order to better understand the baseline health conditions of those affected by the ROSLA, I've plotted here the fraction of individuals who have a body size index above our established threshold. For this figure, we restrict our sample to those born within a year before the ROSLA birth date cutoff and who dropped out of school at age 15. So these are all students who would have been forced to stay in school an extra year if they had been born just a year later. We also divide these individuals into 3 groups based on their BMI polygenic score. Unsurprisingly, we see here that those in the low polygenic score group have a much lower risk of obesity than those in the high polygenic score group. The difference in risk between these two groups is approximately 20 percentage points. In this figure, we show the estimated effect of an additional year of education at age 15 on body size for each of these groups again. Here we see little to no effect of education on the low BMI polygenic score group, but a substantial decrease in risk for the high polygenic score group. The difference in the effect between the low and high group is roughly 14 percentage points. Recall that the risk difference between these groups was 20 percentage points before the reform. This means that this 1 year of education reduced the health differences between these groups by nearly 75%. In conclusion, we see that education can have a substantial impact of improving rates of obesity, and that these effects are concentrated among those with the greatest genetic risk. These results challenge the notion of genetic determinism. Even though polygenic scores can explain a substantial amount of variation for some phenotype, social policies can still mitigate health differences that arise from genetic risk. I'd like to thank the many people who provided useful feedback and research assistance on this project. Also thanks to our funders who supported this work. And last, but certainly not least, a very special thanks to the UK Biobank for providing such a valuable data resource to the entire research community and for organizing this meeting today.
So we liked that one particularly because it made us think that, you know, it's not all in our genes, and that, you know, telling my kids that to do well at school is actually pretty important. Okay, so the runner-up, and I'd love to introduce, is Jiwing He from Harvard Medical School, who I'm very pleased to say could be here with us today. And she's going to talk about the systematic comparison of environmental exposures and polygenic scores to identify individuals at risk for common diseases in the UK. So can I welcome you onto the stage? And I'd also like you to present you with some prize money. Perhaps I should give this to you after the talk. Okay. Take it and run. Okay, thanks very much, Ewan.
Hi everyone, my name's Ishwan. I'm a first-year PhD student at Harvard Medical School. Thank you guys so much for giving me the opportunity to talk today. So today I wanted to talk about how G and X play a role in predicting your disease. So as we've learned in biology classes, P is equal to G plus X, where G is the genetic variance, your genetic predisposition, and then X is different environmental exposures. So these include pollution, your education, like we learned in the previous talk, your diet and exercise and things like that. And then your phenotype is obviously different diseases like type 2 diabetes, lung function, coronary artery disease, and AFib. So G has been very extensively studied, as we've seen throughout the talks. Genome-wide association studies, they are able to identify a lot of variants significantly associated with the disease. So as of May of this year, there's been over 138 associations found. However, the problem is a lot of these common diseases, they follow a common variant model. So this means that a lot of the common diseases are due to a lot of variants as compared to Mendelian diseases, or rare Mendelian diseases, which are usually due to a few variants that have very strong penetrance. So one recent method, as we've learned about, that have become increasingly popular is to look at polygenic risk scores. So this combines individual effects of basically all the variants in a genome-wide association study, and this also accounting for linkage equilibrium. And so this theoretically maximizes the power of GWAS studies, and so this would kind of help solve the problem of the common disease, common variant model. And so this is many of you are probably familiar with this study that was released that was published last year by Kara et al. And so they looked at several diseases, and what they were able to find was they were able to identify individuals who have greater than 3-fold increased risks in all these different diseases. And so on the x-axis here, they're showing the percentile of the polygenic risk score. And then the y-axis is within each percentile, what percent of those individuals have the disease of interest. So as you can see, the individuals in the last few percentiles have a much higher prevalence than those in the lower percentiles. However, there's not as many studies in the exposure side, and so I wanted to talk to you a little bit about how we can study maybe exposures more and why it's important. So I wanted to introduce you first to something known as an exposure-wide association study. So what you're doing here is it's very similar to a GWAS study, but instead of genetic variants on the x-axis, you're looking at different environmental exposures. So with a huge database like the UK Biobank, you're able to study hundreds of environmental exposure variants at the same time. So you can basically associate each of the environmental variants with the disease of interest and plot it in a similar Manhattan plot shown here. And the different colors would represent different categories of the environmental exposure. So you can see, so this is a figure shown for type 2 diabetes. So you can see some peaks for physical activity, alcohol, and smoking. So not very surprising. And then from there, what I wanted to do was actually calculate something similar to a polygenic risk score. And this, I termed this an exposure score, and basically it's calculated in a similar way as the polygenic risk score that we've been talking about in the past talks. And again, so here I'm showing the gradients for type 2 diabetes on the left, and then coronary artery disease on the right. And again, the x-axis is the percentile of the score, and then the y-axis is the prevalence within each of the percentiles. So as you can see, the exposure score is also able to do a good job of separating individuals who have higher at greater risk for these diseases. And so if you look at the last 10 percentile, for example, there's a much higher prevalence of the type 2 diabetes as well as coronary artery disease in those last 10 percentile compared to the rest of the population. So in conclusion, there's a lot of information in environmental exposures, so maybe we should try to incorporate these information into improving clinical care. For these complex common diseases. And these large databases like the UK Biobank are able to allow us to study associations between the environment and phenotypes like we've never been able to before. So I'd like to thank everyone in the RAGU who's helped me with my work, as well as the different funders, and of course UK Biobank. If you have any questions, please reach out to me. Thank you.
Okay, and the final speaker, the final runner-up of this competition is Dr. Baptiste Couvé-Duchesne from University of Queensland in Brisbane. And he's going to talk about something a little bit different than polygenic risk scores, the widespread association between grey matter structure and the human phenome. Thanks very much.
Thank you very much for the opportunity to present today. The field of neuroimaging is at a turning point nowadays following the recent availability of large databases, and the UK Biobank is probably the largest in the world. So I'm going to talk today about a few new analyses, or mostly new analyses that we can do on brain images and that have been inspired by the field of genetics. So why getting the inspiration from genetics? And that's because studying the genome or studying brain images have things in common, and mostly the fact that we're dealing with really large number of measurements and really complex data sets. So the first concept that has been previously coined as morphometricity, and which I'm going to present today, is the total association between a phenotype and all the brain measurements that we can get from a brain image. And this is analogous to a SNP heritability, if you're familiar with the genetic world. Similarly, the genetic correlation, when we transpose SNPs into brain measurements, becomes the gray matter correlation that gives us an idea of whether the morphometricity of the traits are shared. And finally, the same way that we develop polygenic risk scores, we can start building gray matter scores that can help us predict from the brain images themselves. So we processed the images ourselves, combining the T1 and T2 weighted MRIs. And then we processed first the cortex using FreeSurfer, and the subcortical volumes using the Enigma protocols that are released, made freely available. And this led us with about 650,000 measurements per individual, mapping the cortical thickness and surface area, as well as the subcortical shape, or rather thickness again and area. So if you come back to the genetics, this is basically the size of a GWAS chip that we're now dealing with, but consisting of brain measurements. When we look at the brain morphometricity, hence the total association between phenotypes and the 600,000 brain measurements, these are the 58 phenotypes for which this association was significant in the UK Biobank. So this is on the first 10,000 image participants, and this is 58 phenotypes presented here out of a list of 175 that we selected from the UK Biobank. As you can see, there are large associations between age, sex, and body size, and the gray matter structure, which is in yellow in this circular bar plot. And we also found interesting associations between the gray matter shape, gray matter structure, and the maternal smoking around birth that you can see at the bottom there, but also with depression score and symptoms, substance use, alcohol and tobacco, as well as lifestyle measurements of activity levels, or even diet, self-reported diet questions. We looked at the replication in a subsequent 5,000 image participants of the UK Biobank. And as you can see in this XY plot, 23 out of 58 associations replicate in this smaller sample. And the point estimates were very similar across the replication and discovery samples. Now taking it to a bivariate level and looking at whether this morphometricity is unique to the traits or shared between pairs of traits. We estimated the gray matter correlation shown above the diagonal, and you can contrast that to residual correlations below the diagonal. So remember, we cannot infer any direction of effect here, because we're dealing with the brains and not with the genome anymore. So these can reflect causal, bidirectional relationships between the variable, and also all the associations with the brain could be causes or consequences of the phenotypes that we're studying. Yet we found a lot of large and significant gray matter correlations between some of the traits reported and measures of body size, such as BMI or body fat percentage. So this means that the morphometricity that we identified is not necessarily unique, but rather shared between some of the traits. And for the case of depression, for example, or diet or activity levels, the signal that we detect, the association we detect with the gray matter structure comes from the from the covariance of those phenotypes with body size. This is quite interesting because it can help us revisit some of the brain markers that have been identified for depression, for example, so further characterize them. But it also opens the way for transfer learning, which is a way of studying one phenotype by studying instead a related phenotype. I'll show an example in a minute. And then finally, to conclude on the prediction level, then we built gray matter scores, so weighting each individual vertex of the brain and combining them, summing this risk across the whole brain. And then we could make significant prediction for 56 out of these 58 phenotypes using a tenfold cross-validation on the discovery cohort. 42 of these scores were predictive in the UK Biobank replication sample and could even predict some phenotypes in the Human Connectome Project sample, which is much smaller and composed of younger adults from the US. So as you can see, the prediction varies greatly, and it's relatively good for age, with a prediction R-squares of almost 0.6, and it's much lower for the phenotypes that show lower morphometricity. What was interesting, coming back to transfer learning, is that we actually do better at predicting depression score by using a gray matter scores for BMI, rather than using a specific gray matter scores for depression. And that's due to the shared signal that we identified previously. And I think our example also shows that you can now apply those scores to completely new cohorts and basically study phenotypes that have not been collected, such as maternal smoking around birth in the HCP that correlated with nicotine dependence at adult age. And I would like to finish by thanking all the people who made this study possible. So my lab heads and colleagues and co-authors in Brisbane and in Paris, and most importantly, all the UK Biobank participants and staff. Thank you for your attention.
So hopefully those three examples really do showcase the diversity of fantastic research that's been done using UK Biobank by talented researchers from all over the world. So it is fantastic to see it being used in this way. So if you haven't already done so, please take the opportunity in the tea break, which is now, to grab a cup of tea or coffee and have a look at the posters. I've got strict instructions to tell you to be back here for 3:30, so we've got 20 minutes for the next session. So thank you very much.